Okay, I'm gonna start with my machine check. So my O2 auxiliary tank, I'm gonna crack and take a look at it, make sure it's at least half full, and close it. I'm gonna check my pipeline PSI for my 3 gases that they're all at least 50. And then I'm gonna look at my vaporizers, make sure the interlock system is working, if the caps are on tight and if they're full. While my machine's off, I can do my low pressure test. I'm gonna look at my suction, make sure that's working appropriately, and make sure my anti-gag's working. I'm gonna look at my alarm parameters, make sure they're set up for an adult patient, and make sure I have my EKG, blood pressure cuff, and pulse ox ready. And I'm going to turn on my machine now. I'm gonna check my CO2 absorber, make sure it's not desiccated or exhausted. And then I can do my O2 analyzer test as well. I'm gonna do my high pressure leak test. So I'm gonna close the APL valve to 70 and apply the O2 flush with inclusion, and I should be able to maintain 30 centimeters for at least 10 seconds. And then I'm looking at my in-story-exstory valves, make sure they're fluttering, and making sure I can apply the positive breath, which I could. I have her mask ready to go. I've got my vent settings programmed on here for her size. And then I have my 80 ET tube that I'm going to use today with a half size below and a half size above. I have an oral airway, and I'm going to be using a MAC 4 blade for her. And I have my apples and induction drugs as well. And I have tape to taperize. And so I'm going to introduce my patient now. So this is Grandma Rosalie. She's 120 kilos and she's 5'7", so her BMI is 40. And she's here today for a lap chole. She has acute cholecystitis, and she has a history of uncontrolled diabetes and hypertension, so she's an ASA class 3. And I reviewed the patient's charts and labs and making sure I get a blood sugar for her uncontrolled diabetes as well. And for this reason, she's going to be a full stomach and RSI today. So next I'm going to do my exam with the patient. I'm going to do her airway exam first. I'm going to check her Mallampati score and her upper lip height, which she's a class 1. I'm going to check her thyromental distance, which is greater than 6, which is adequate. And I'm going to check her incisor gap distance, which is 6 centimeters, which is normal. And now I can auscultate her heart and lungs. I hear a good S2 or S1, S2. I hear clear lung sounds. And then I'm gonna kind of ask her some questions. Have you ever experienced a syncopal episode? Do you ever experience dizziness, or do you have any paresthesias with range of motion in your neck? Do you have any chest pain or shortness of breath? Can you walk up a flight of stairs? Do you have any heart problems I need to know about? Any asthma history, any kidney liver disease other than your diabetes, and any exercise intolerance. And then I'm going to assess NPO status. So I'll ask her, what did she have for breakfast? Have you had a recent cough, cold, or flu? And then have you had any complications with the anesthesia in the past? Does your family have a history of like high fevers with anesthesia, or a history of bulimic hyperthermia? And then have you ever been hospitalized? Okay, and now I'm going to explain what I'm going to do for anesthesia today. I'm planning on a general anesthetic for a lap chole, and I will be putting in a breathing tube and keeping you asleep throughout the procedure. And some of the risks of this is that you can, because of the immobility post-op, you can have a potential for venous thromboembolism. You can have hemodynamic instability during the case. You can also experience airway issues such as like hoarseness or soreness in your throat from the ET tube. You can also have some post-op nausea and vomiting as well. And she is going to give me consent, and I'm going to give her 2 milligrams per sed. The other alternatives I can explain too is we could do a spinal epidural, but because of the sensory level required, it's a little high than what I think is the best course of action. And then another potential is like doing a tap block too for pain. The benefits of the general anesthetic as well is that we can control CO2 better with the insufflation that we'll have to use during the laparoscopic procedure, and then also helps mitigate the risk of aspiration too, especially since she's a diabetic. Okay, So after I give that 2 milligrams of Versed and get her consent, we're gonna go back to the OR. Because of her size, I'm gonna use a ramping position for her. And then I'm gonna start to pre-oxygenate the patient with 100% using the EC technique, and I'm gonna be using CPAP as well. And then I'm gonna check a baseline train of 4 here before my RSI. I'm at the orbicularis oculi muscle that's testing the facial nerve. And then I'm gonna push my induction drugs. So I'm gonna give 100 milligrams of lidocaine, followed by 100 mics of fentanyl. And then I'm gonna give her 120 milligrams of propofol and 145 milligrams of rocuronium for an RSI induction. Okay, once the paralytic has kicked in, I'm gonna have the nurse help me with cricoid pressure. And then I can DL my patient. Once I see the cords, I'll put the tube through the cords. And then I'll pull the stylet out right as the tube's passing the cords. And then I'll see misting in the tube. I'll auscultate bilateral left breath sounds. And then I will be able to see my capnography as well to confirm that I'm in the airway. And then I'll make sure that the 8.0 tube is at 24 centimeters at the teeth. And then I'll be able to tape it down and secure it, and then I'll inflate the pilot balloon. And I'll turn my SIBO up to 2% for maintenance for the case. Okay, so when it comes to extubation, she's gonna be an awake extubation because of her, she has an RSI and she's aspiration risk. So I'm gonna make sure she wakes up fully and I get all my twitches back. So at the end of the case, I check switches and I only get 1 twitch. And I'm gonna be checking recovery here at the adductor pollicis, which is the ulnar nerve. And I only get 1 twitch on my train of 4, so I'm gonna be using neostigmine and glyco as a reversal. And so because I only got 1 twitch, I know that my train of 4 is less than 90%, so I know I have to get above that for my patient before I extubate them. So my dose for neostigmine is going to be 5 milligrams, and then I'll put glyco in the same syringe. And the duration of the neostigmine is 45 minutes to 90 minutes, so it does wear off faster than the glyco. But the nice thing about glyco too is it doesn't cross the blood-brain barrier like atropine does, so you won't get any CNS effects like you do with atropine. And once I've given my reversal agent, I'm going to make sure she can lift her head up off the bed and squeeze my hands for at least 5 seconds. And that will indicate that I have at least 50% of receptors not occupied. Okay, so I'm going to suction her out, deflate the cuff, make sure she's sitting up in an upright position, and I've been hyperoxygenating her at this point. And then I can extubate. When we go to PACU, I'm just going to give a report. This is Rosalie. She's a 120 kilo female presenting with acute cholecystitis. We did a lap chole today with a general anesthetic and an AT tube. She has a history of diabetes and hypertension. Her EVL was minimal. I did give 250 of LR in the case, and her hemodynamics were stable throughout the procedure. She can have some Zofran and fentanyl in the PACU, and then her last vital signs. We're not